Здравствуйте. Сталкиваясь в работе с реаниматологами, убеждаюсь, что представление об экстракорпоральной детоксикации по большей части у специалистов интенсивной терапии наших больниц основывается на сведениях из рекламных буклетов, прилагаемых к аппаратам и к компонентам, и той информации, которую доносят до врачей медицинские представители фирм, занимающихся производством, продажей аппаратов заместительной почечной терапии, колонок для детоксикации. Совсем недавно на конференции заявление довелось услышать о том, что якобы международные рекомендации по сепсису получили обновления, в которых средства экстракорпоральной детоксикации рекомендуются пациентам. Вопрос абсолютно не решен. Никаких обновлений в международных рекомендациях по сепсису о том, что применение цитокиносорбции, других методов гемофильтрации помогает пациентам в состоянии сепсиса, никаких обновлений нет. По-прежнему мнение единое о том, что доказательства клинического эффекта методов очищения экстракорпоральной крови нет. И для того, чтобы не голословными были мои замечания, я записал вебинар, который был проведен неделю назад, 3 октября 2023 года, экспертами Европейского общества специалистов по интенсивной медицине. 2 профессора с большим опытом работы по применению методов экстракорпоральной детоксикации, заместительной почечной терапии в виде дискуссии. Сам вебинар вот здесь, это официальный сайт Европейской ассоциации специалистов по интенсивной медицине. Доступ свободный, но требуется регистрация для того, чтобы просмотреть, прослушать вебинар. Не все себя утруждают этой регистрацией. Так вот, название вебинара. Имеется ли будущее для очищения крови, для экстракорпоральной детоксикации в отделениях интенсивной терапии? Дебаты за, против. Для невладеющих языком докторов могу посоветовать включить, я не знаю, не смотрел, но в Ютубе должны включиться автоматические субтитры. А так, в целом, по этому часовому вебинару профессор из Лиона, работающий в интенсивной терапии, задискутирует, но за то, чтобы продолжать исследования, за то, чтобы выбирать группы пациентов, для которых действительно сорбции цитокинов, сорбции эндотоксинов полисахаридных, бактериальных может помочь. То есть требуется обследование. И профессор из Швейцарии, Цюрих, руководитель университетского отделения интенсивной терапии, нефролог, реаниматолог, он приводит информацию, которая не позволяет им в швейцарской клинике своей применять методы экстракорпоральной детоксикации у своих пациентов. Внимание мое, кроме того, привлекла эта дискуссия тем, что не только при бактериальных сепсисах, а при вирусном сепсисе, в том числе при сепсисе, вызванном вирусом геморрагической лихорадки с почечным синдромом, тяжелое течение ГЛПС, заместительная почечная терапия и методы другие экстракорпоральной детоксикации по моему опыту не дают положительного эффекта для пациентов. ГЛПС – заболевание самоограничивающееся, заканчивающееся выздоровлением самостоятельно без нашего вмешательства или же с минимальным вмешательством в терапию. И применение внешних контуров циркуляции крови по пластиковым трубкам, какими бы они ни были совершенными, у больных ГЛПС, у которых серьезное нарушение гемокоагуляции, как тромбоцитарного, так и гуморального звена гемокоагуляции. Так вот, применение внешней циркуляции, контуров внешней циркуляции крови провоцирует тромбирование, повторное тромбирование очень часто сосудов микроциркуляции. Сама по себе ГЛПС – это заболевание, протекающее с тромбообразованием в венозном русле микроциркуляции. Но больные справляются сами. Тромбы в конечном итоге лизируются системой фибринолиза, и начиная с 7-8 дня болезни у пациентов устанавливается равновесие системы активации свертывания крови и системы фибринолиза образующихся тромбов. Если вмешаться чем-то нарушающим гемокоагуляцию, положительного эффекта нет. А для того, чтобы более отчетливо себе представлять, что пластик действительно вызывает эффект тромбообразования, обратите внимание на внутривенные катетеры, установленные у пациентов, которые склонны к тромбированию. Если даже небольшой катетер небольшого диаметра вызывает тромбообразование, что приходится думать о том, что происходит при циркуляции по внешнему контуру. А слова иногда приходится слышать о том, что сейчас не используется гепарин, используется цитрат, препятствующий тромбообразованию в картридже, они никакого, они ни о чем. Это не применение цитрата не препятствует тромботическим процессам. То, что без гепарина, ну хорошо, нет кровоточивости. Но проблема не столько в геморрагическом синдроме при ГЛПС, сколько в тромботическом синдроме, который в конечном итоге является провоцирующим и ишемическим, и некротическим изменением в легких, в почках, в других тканях. Ну и повторно тромбируясь, полностью истощая запасы факторы свертывания крови, пациент доходит до такого состояния, где и без дополнительного гепарина он подвержен развитию тяжелого кровотечения. Так вот, еще раз, к тому, о чем эксперты интенсивной терапии европейские говорят. Доктор, который говорит за продолжение исследований детоксикации экстракорпоральной, за новые колонки сорбирующие антицитокиновые, он подчеркивает, что требуется продолжение исследований по той причине, что есть положительные результаты, но эти результаты в других исследованиях не воспроизводятся. Для примера и наши российские исследования приводятся, где были получены положительные результаты, но никому повторить эти положительные результаты не удается. Доктор, который говорит о том, что в рутинную практику сейчас внедряться эти методы не должны и больше вреда приносят экстракорпоральное очищение крови для пациентов с сепсисом. Он соглашается с тем, что требуется продолжение исследований, но на очень узких группах пациентов. То есть надо найти, если уж так хочется применять экстракорпоральную детоксикацию, надо найти тех пациентов, которым это может помочь, не навредив основной массе больных. Ну и в конечном итоге там в конце дебатов ведущий конкретный вопрос задает, как поступать врачу, который завтра приходит на работу, у него тяжело больной, и решать вопрос, проводить ли сорбцию цитокинов пациент с сепсисом или же отказаться от этой процедуры. Так вот, дискутирующий в вебинаре за применение сорбционных методов терапии профессор признает, что он бы использовал эту терапию у конкретного пациента только в том случае, если пациент находится в течение 24-48 часов в состоянии рефрактерного септического шока, и доктор уверен в том, что уверен в неблагоприятном прогнозе заболевания. Применение этой терапии только как средство отчаяния. Ну, а разумеется, профессор, который рассказывает об отрицательном опыте этой терапии, он говорит о том, что ни в коем случае в рутинной, в стандартной практике применяться эта терапия не должна. Вступление длительное получается, но, еще раз повторяюсь, очень агрессивные производители техники дорогостоящие выходят на наш рынок и доносят информацию до врачей неверную. Зомбируются доктора. Так, неправильно термин использовал, нет. Похоже что-то на гипнотическое воздействие на наших докторов, которые уже ничего не слышат о том, что терапия может быть опасна. Она действительно может быть опасной для пациента. Все, дальше меня не будет. Дальше текст, вернее не текст, а дебаты, вебинар, проведенный действительно ведущими специалистами в этой области.
Hi, my name is Nicole Jeffermans. I'm the editor-in-chief of ESICM Experimental. Before handing over to the moderator of today's session, Professor Peter Pickers, I'd like to take this opportunity to welcome you to this ESICM webinar that is organized by ICMX. The topic of today is blood purification. And this is an example of a potential therapy for ICU patients, but still with many remaining knowledge gaps. Thereby, it excellently fits the aims and scope of ICMX. I'd like to draw your attention also to the fact that ICMX has launched a topical collection on blood purification This means that we specifically welcome submissions on this topic. And with that, I would like to wish you a pleasant Procon debate, and I hand over to Professor Peter Pickers.
Thank you very much, Nicole, for this nice introduction. Good afternoon, everybody, or good morning or evening, depending on where in the world you are. This webinar has two excellent speakers that are experts in this field. We will first have Professor Thomas Rimelet from Lyon, and second, Professor Sasha David from Zurich. And they will talk about blood purification. And as was alluded to, this is a very interesting theory of making or getting the toxic elements out of the blood, especially in patients with sepsis. Some of these techniques are focused on the endotoxin that might be circulating. Some other techniques are focusing on removal of cytokines. And while this is a very interesting theory and that might be beneficial for patients with septic shock, it is difficult actually to prove that these therapies show benefit for the patient, clinical benefit. So I'm very much looking forward to their talks if this is a treatment that is ready for prime time in daily clinical practice. So I'll give the word first to Professor Thomas Rimelet. He is a specialist in anesthesiology and intensive care. He works in Lyon in France. He has a couple of hundreds publications, among those about blood purification. So I'm very much looking forward to your talk. Thomas, the floor is yours.
Well, thank you very much, Peter. It's a pleasure to be here with you guys for this 1 hour. We're going to have 1 hour speaking on blood purification. I think we're going to have a good time. I would like to thank very much the ESICM for inviting me to this webinar. So is there a future for blood purification in the ICU? I'm going to do the pro, and Sasha is going to do the con in 30 minutes. These are my conflicts of interest, and this is the outline I'm going to follow. Come on, Sasha. Of course, there is a future for EBP, extracorporeal blood purification, in the ICU. I'm going to briefly introduce the topic, and then I'm going to explain why I believe there is a future with the pathophysiology. I'm going to briefly explain the different techniques for extracorporeal blood purification, the ones that are available in 2023. And I'm going to end with the different research questions that we should be focusing on during the next upcoming years. So in terms of introduction, I think I'd like to propose 2 slides on epidemiology because they are new and I think they are very important. First of all, 3 years ago, it's a publication from the US, 6 academic centers, and they looked at the different causes of death in the hospitals. We know that sepsis is the primary cause of death in the ICUs. We know this for a long time now, but we didn't know that it's also the primary cause of death outside the ICUs, actually, in the hospitals. The primary cause of death is clearly the sepsis in front of the cancer and in front of cardiac disease. Another important publication in terms of sepsis epidemiology came out 2 years ago in the Lancet. They looked at all the deaths worldwide from all causes. And I didn't know that 50 million people die every year from all causes. It's actually 1.5 deaths every second. 50 million is also the number of cases of sepsis diagnosed worldwide, and they recorded 11 million people dying of sepsis, which means that sepsis represents 1 in 5 deaths worldwide, which is actually twice as many as we previously estimated. So the message here is that sepsis is twice more frequent as we thought before. I think this is very important to remind everyone this to start with this webinar. Also, what is important to remind to our audience is that 100 years ago, Sir William Osler said that except on few occasions, the patient appears to die from the body's response to infection rather than from it. So I think the immunoinflammatory response is extremely important to be taken care when we treat sepsis. Actually, 15 years ago, the pathophysiology of sepsis was reported by Richard Hotchkiss, and he reported that the immunoinflammatory response, it's actually a double inflammatory response with two components, a pro-inflammatory component and anti-inflammatory component. And the net balance is more the pro-inflammatory side during the first hours, first hours before sometimes the ICU admission. And when after this time, when the patient gets to the ICU, there is this immunosuppression state. And this immunosuppression state is extremely deleterious for the patient because at that moment, the patient cannot fight against nosocomial infections, cannot fight against viral reactivations. This immunosuppression state and this hyperinflammation at the very beginning, all of this is due to the release of all these inflammatory mediators. So I think it's very logical to try to improve sepsis targeting these inflammatory mediators. Actually, this is written in the sepsis definition. If you look at the first sentence of the current sepsis definition, it's written that sepsis should be defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So once again, it's very logical to target this host response because we know from the definition that it's dysregulated. So we need to improve outcomes by targeting this host response. So I believe that now, today, and actually it will be even more true in the future, that immunology is clearly part of our daily life in the ICU. We are going to work more and more with immunologists in the ICU. For the sepsis management, even if we do everything very well, antibiotherapy, source control, organ support, when everything is managed correctly, then the prognosis is still dramatic, right? With all this epidemiology I have just reminded. So that's why we need something else. We need adjuvant therapies to improve patient outcomes. And that's why we propose immunomodulation. So there is immunostimulation and some drugs, some molecules are under assessment at this time, IL-7, GM-CSF, interferon gamma. But this is also why all these extracorporeal blood purification techniques are under investigation. So in terms of pathophysiology, how does these techniques exactly work? Do we know that? No, we don't know. I think this is a good point for Sasha because we don't really know how these techniques work. If you look at on the left side of the slide, this is the pathophysiology of sepsis-induced acute kidney injury. And when we implement a circuit, an extracorporeal circuit, a membrane, a renal replacement therapy machine, or a cartridge for blood purification, we don't really know how these devices interact with sepsis-induced acute kidney injury, with the pathophysiology. And that's this is a big issue. We don't know, for example, all of these are hypotheses. We don't know if the target should be the endotoxins, if the target should be the cytokines, if the target should be the chemokine concentration gradient between the infected tissue and the circulation. We know that this gradient is very important because this gradient drives the leukocytes to the site of the infection. So it may be a good idea to target this gradient with a blood purification device. Also, we know that these new devices, they are able to provide an interaction between the sorbent and the leukocyte. And this interaction can lead to a modulation of the expression of some leukocyte surface markers that are important, such as HLA-DR. We also know that these devices can absorb directly the leukocytes at the surface of these beads, for example. Is it good to remove from the blood activated leukocytes from sepsis? I don't know. But actually today, in 2023, this is technically possible. What are the different techniques in 2023? So I have classified them in 4 categories. The first one is all the sorbents, what we call hemoadsorption. And you can see we have polymyxin B hemoperfusion, cytosorb, Alteco technology, the Jaffron technology, Biosun technology. Then we have the CRT filters, some specific filters with enhanced adsorptive properties like Oxaris, like PMMA, or some high cutoff membranes like the AMIC2 membrane from Fresenius. We have the old techniques like high volume hemofiltration, plasma exchanges, CPFA, and we have new techniques, very promising, like the Seraph, for example. I'm going to say a few words on a few of these techniques. Let me start with high volume hemofiltration, because this is the oldest technique that have been proposed for blood purification for sepsis. We had a lot of data in the 1990s and in the early years of 2000, but then the publication from our good friend Olivier Johannes Boyot with this large multi-center randomized control trial, the IVOIR study, could not show any benefit for with high volume hemofiltration. The survival, the 90-day survival, was not different between high volume hemofiltration and standard hemofiltration. Now we're going to talk about plasma exchanges, and I know that Sasha knows very well about this because he made a few publications. I'm going to come back on that. The first publication on plasma exchanges came out in 2002 from a Russian team, Rolf Busun, and it was a very promising results because they found an improvement in survival with plasmapheresis in septic shock patients. So I was very surprised that after this publication, no one came to confirm or not confirm these data. We had to wait 20 years to get additional publications on plasmapheresis in sepsis. This is another randomized control trial from the Middle East with Canadians and Americans involved in this project. And the results were also quite promising because there was no difference in terms of survival between plasmapheresis versus standard treatment, but the patients recovered quicker. The SOFA score was improved quicker with plasmapheresis than with the standard treatment. But also now, during the last 2-3 years, we got several publications from Sasha. And this is one of his publication. It's a randomized control trial looking at plasma exchanges in septic shock. And what Sasha reported is like an improvement in hemodynamics in the patients who received plasma exchanges. So there was no difference in terms of mortality, but two groups of 20 patients, it was difficult to show anything in terms of mortality, but still a clear improvement in terms of hemodynamics with plasma exchanges. And he also reported this kind of data in critical care last year, with also an improvement in hemodynamics in patients who received plasmapheresis as compared to the control. And the lactate level was also decreased faster with plasmapheresis as compared to the controls. A few words about the hemodabsorption techniques. So we have different devices: polymyxin B hemoperfusion, the Jafron technology, Biosan technology, cytosorbs, and Alteco technology. When it comes to polymyxin B hemoperfusion, of course, I think Sasha is going to talk more about this trial because it's a negative trial. It's a large multi-center randomized control trial looking at polymyxin B hemoperfusion in septic patients who came to the ICU because of severe peritonitis. Polymyxin B hemoperfusion did not show any benefit in terms of 28-day mortality in this publication. Same results with the Euphrates trial that you may have heard about. No difference in terms of mortality between polymyxin B hemoperfusion versus the control group. However, what is very important, this slide shows that when the investigators could focus on a subgroup of patients, could select a specific subgroup of patients, the ones with a EAA with an endotoxin activity of 0.6 to 0.9, then a difference was observed in favor of polymyxin B hemoperfusion, showing that when you select correctly your population, when you the population you want to study, you can find interesting results in terms of mortality. Of course, this is a sub-analysis, so you can criticize it, but this should be useful to design the next trials. Cytosorb technology, what I want to show here, it's very interesting because when you run the blood through this device, you can see that there is a huge surface of exchanges. So when you want to absorb cytokines on this device, you can absorb theoretically a lot of cytokines because there is a huge surface of exchanges. Cytosorbs can absorb from the blood a lot of inflammatory mediators, pro-inflammatory cytokines, anti-inflammatory cytokines, DAMs, PAMs, hormones, chemokines, but also antibiotics. So what we have to say here is that when you try these techniques, when you have a patient under these therapies, under blood purification, it's important to do therapeutic drug monitoring because you don't want to remove from the blood antibiotics. So when you use this device or another one, when you use blood purification, please be very careful that you are not going to be harmful by the removal of other beneficial molecules, of course. I want to show also this case report, which is very amazing. When I read it, it's a peripheral gangrene of limbs. And then the patient here, he got a session of Jafron hemoadsorption, and a few days later, the situation got improved very well. So interesting results with hemoadsorption. Now I'm going to mention high adsorptive hemofiltration with the Oxaris filter. The Oxaris membrane, this is a renal replacement therapy membrane with enhanced adsorptive properties, and these properties allow this membrane to absorb at the surface of the membrane endotoxins and cytokines. That's the targets of this renal replacement therapy membrane. In terms of data, there are several articles in the literature. I just wanted to report the one of the last publications. It's a publication from Marcus Broman. It's a randomized controlled trial comparing IN69ST to Oxaris in septic patients, and they could show that the decrease of the endotoxin level was more important with Oxaris than with IN69ST, although the level of endotoxin at the very beginning was a little bit different between the two groups. Let me talk a little bit about the high cutoff membranes, which also are proposed for blood purification. The idea here is to increase the size of the pores of the membrane in order to remove more inflammatory mediators, because inflammatory mediators are, for most of them, middle molecules. So if you increase the size of the pores, you can remove more inflammatory mediators. But you cannot increase them too much because you don't want to remove from the blood albumin. So you have to use like a cutoff between 40 to 60 kilodaltons, so you are not going to remove the albumin, and you need to use this membrane in a diffusive mode in CVVHD if you want to use this membrane. This membrane can also be used for myoglobin removal in rhabdomyolysis, or if you want to remove immunoglobulin light chains in case of multiple myeloma. That has been described also in the literature. Let me also talk a little bit about the Seraph, because this is a new interesting device. How does it work? You have these polyethylene beads here, and the company has grafted immobilized heparin on the beads, on the media. So the bacteria here, yes, the bacteria can be absorbed directly on the media. So you're not removing here, when the target here is not really the cytokine, the endotoxins, the leukocytes. This is the bacteria themselves. At the very beginning, this device was proposed for, multi-resistant bacteria, and it actually works very well to remove from the blood multi-resistant bacteria. But then they realized that it's very useful for random bacteria, because the prognosis can be improved by this removal. It was also tested during the COVID pandemic, and we have two registries, one US registry and one European registry, and you can see here very interesting results during the COVID period when the patients with COVID, severe COVID patients, they got Seraph sessions, then the survival was improved as compared to historical controls. Of course, this is not so as robust as a randomized controlled trial, but there is a signal here for the improvement of the situation with this device. Interestingly, the European device, they found exactly the same figure, an improvement of the survival with the Seraph in case of severe COVID patients. In my institution, we use with Céline Mona, we use the device in the intraoperative period in specific patients who have infected vascular graft. And during this surgery, with the prognosis is usually very bad. During this surgery, the bacteria are released in the blood. So we thought it could be interesting to absorb these bacteria on the Seraph here during the procedure. The surgeons, so there is no heparin going to the patient here because there is citrate in the machine. So, but the prognosis has been improved dramatically thanks to this technology. And now I can tell you that our vascular surgeons here, they really do not want to operate another patient without the machine working beside them. So this is reported in this publication. So now I would like to end this talk with research questions that I think we should be focusing on during the next years. So when you go to a meeting, you can hear sometimes some physicians saying that, yeah, the blood purification therapies, all the studies are negative, it doesn't work. I think we should definitely disagree with this for several reasons. First, we have to be honest. It's totally wrong and not true to say that all the evidence, all the studies are negative. I can show you different slides with different publications with positive data. This is positive data from Professor Kellum in Pittsburgh, 10 years ago. It's a meta-analysis with MO adsorption. It's positive results. We have positive results from Claudio Ronco, the UFAS trial published in the JAMA, also more than 10 years ago. Positive results in terms of survival. Yeah, the study was criticized, but still we have this data, and the study was stopped because the ethical group could not accept that the control group will not benefit from the therapy. So you can see that we have positive data here also. This is also positive trial, another positive meta-analysis. And this sub-analysis from the Euphrates trial that I've shown before, when you select your population correctly, you can get positive results. And actually, Sasha, you did the work 3 years ago. You looked at all the literature, and you said that you have in green you have the positive studies reporting interesting results in terms of improvement of outcomes in these septic patients who received a blood purification technique, and in red the negative trials. So actually, yes, it's a very balanced literature with articles showing an improvement and with articles showing no benefit. That's why it's a debate today, and actually I think we don't have the right answer at this time in 2023, and that's why I believe that more research should be done in this field. So I can tell you that Sasha is going to tell us that we have negative trials. The EVOA trial is negative, the Abdomix trial, the compact one, the Euphrates. I don't know if he's going to say that in English because, yes, he's German, but he works in Switzerland. So he can say it in French, he can say it in German, he can say it in Italian, but he's going to say it. Let's see how he's going to say that these trials are negative and that there is no future for blood purification, which I think I believe he doesn't believe it really because he published interesting results in this field. So let's see how he's going to propose, what he's going to say for these techniques. So maybe you don't believe me, you don't believe Sasha, and so you can believe these guys. These guys are the experts, the big experts in the sepsis management. And every 4 years, like the Olympic Games, they propose their knowledge, they propose their recommendations for sepsis management. And during the last 2 sessions, for 8 years, there have been the question, what do you think about the blood purification device? And the answer is always the same. Our confidence in the evidence is very low, either in favor or against blood purification techniques. Further research is needed to determine the effect of various blood purification techniques on patient outcomes. So yes, we need additional research in this field. Why are these studies negative? I think one of the reasons is this one. If you take a too large population, if you want to test a blood purification device, you take a large population because you want to publish in the New England Journal of Medicine or in intensive care medicine. And so you take a lot of patients. Then you do the statistics on the whole population. You get a negative trial and you don't see the positive results you can have on a subgroup of patients. And I believe the Euphrates trial in the US, that's exactly what happened. So if you don't select correctly your population, you get a negative trials. This is also because sepsis is a very heterogeneous syndrome, right? If you look at all the control groups of all these international trials, the mortality rate goes from 20% to 60%. So not all the sepsis are the same. And that's why we need to target, once again, very well your population. Another publication saying exactly the same thing. If you take 2 sick people, 2 sick patients, you can do whatever you want with the best therapies ever. The patients are going to die anyway. If you take not so sick patients, then you will not be able to show the difference because all the patients will survive. That's why we need to target correctly your population you want to study if you want to show the benefits of one blood purification therapy. Last but not least, I think there is the technological progress that we can see every year, because every year the different companies from the industries are coming to us to propose new devices capable of removing from the blood everything. The cytokines, the endotoxins, the leukocytes, now the bacteria, even the COVID, everything can be removed because of the technological progress. But here, this is Sasha, this is Peter, this is me. We are working, but we are quite slow. We don't go that fast, not because we are not so good, but also because this is research. We need approval. It takes time. We need the approval of the ethics committee. We need to get funding, whereas it's complicated. And I really believe that there is an increasing gap here between the technological progress and the medical knowledge. It's not so good, I think, because it leaves us with a lot of unanswered questions. That's why we are here today, actually. How do these therapies exactly interfere with sepsis pathophysiology? Which patients we should enroll in the trials? When exactly we should enroll these patients? Because when they get to the ICU, they are not at the same moment of the sepsis time course, right? And what to ultimately remove? That's very difficult and very complex questions. So my conclusion, my take-home message, of course, Sasha, come on. You are one of the researchers who published positive results for blood purification. So I believe we should continue research in this field. In 2023, immunology is now part of the sepsis definition. For sure, it's our daily clinical practice. Immunology will be part of our daily clinical practice in the future. As I said in the beginning, patients that die of septic shock because of immunosuppression. Will extracorporeal blood purification techniques be one day part of sepsis management? Well, these techniques are under investigation, but please do not stop to investigate. The multi-center randomized control trial, they are negative. Sasha is going to show that, I'm sure. But let's be honest, also these randomized control trials, they were also full of limits. So we have to take also account of the limits when it's negative trials. We have many unanswered questions. I said it before. So yes, Sasha and Peter, please, research in this field should definitely continue in the future with better designed experimental and clinical trials. I'd like to end this talk with this quote for Norman Vincent Peale. It's always too soon to quit. Thank you so much for your attention.
Thank you very much, Thomas, for your very passionate presentation. A very clear overview of the pathophysiology and how the different adsorbers work, and that some Adsorbers focus on endotoxin and others on cytokines, etc. I'm a little bit disappointed because you told everybody that I'm slow, but nevertheless, thank you very much. We will continue, but before we do so, I want to stress that everybody that is watching this, you can actually put in your questions or comments for the speakers in the chat box. And so at the end of this webinar, we will have a discussion and I will look and try to make a selection of questions that the speakers can address. So please, if you have any questions for Thomas, put them in the chat box and they will come to me and we will discuss these at the very end. So then I want to introduce the next speaker, as I said, Professor Sascha David from University Hospital in Zurich. He's the head of the medical ICU there. He's both an internist, a nephrologist, and an intensivist. And so he will try to explain why we should not use blood purification at this moment. The floor is yours, Sascha.
Thank you very much, Peter, for the introduction. And thank you very much, Thomas, for this entertaining talk. I really had fun listening to you. So someone has to do the job. So that's why I have to talk about the con perspective now. And I'm not only showing the trials, I will also give some conceptual ideas about things that we don't really understand so far, so that we don't have clear in our head. So as an my introduction will be very short, but it's the same basis. If you look at the definition from 2016, there is organ dysfunction, there's host response, and there's infection. And the treatment strategies are extremely limited. Two main columns of the armamentarium that we have are tackling the infection, and the supportive therapies are only there to support failed organs. But the one link that's really missing here is the specific treatment that will tackle the host response. Thomas has alluded to this extensively. And this is the birth hour of the purification of diseased blood, if you want so. And the first person who really introduced this 80 years ago was a Dutch guy, Willem Kolff, who essentially performed the first successful renal replacement therapy in terms of a purification of the blood. A young woman with a uremic coma that woke up using this kind of funny device. So 80 years later, we now have much more options in our armamentarium to treat blood purification or to use blood purifications. And Thomas has shown a structure with 4 different scenarios. I have here the typical renal replacement therapies summarized, adsorptive devices, and there are many of them. We have heard about some, and the apheresis strategies. And for time reasons, and also to keep it a little bit more simple, we will now focus on the absorptive technologies. We have heard about this already a little bit from the pro perspective, but I will show you now a con view on these devices. So it all started definitely with the hemoperfusion with charcoal, and the older ones will remember this. 25 years ago, this was a technology that used perfusion and to absorb toxins. And I want to highlight the difference between adsorption and adsorption, because this is always made wrong. You can see the girl on the left-hand side here, a nice example for an absorption. So particles soaked into the bulk of the other face. This is not what we're doing when we're adsorbing toxins or injurious molecules. We're doing what this boy on the right-hand side is doing. This is adsorption. The particles stick to a surface of the other face. It's a totally different concept. And you can imagine that this chocolate or whatever it is still probably producing some trouble in the face of this boy. Totally different from the girl scenario. So when you're talking about adsorption, there are 2 contexts. One is the whole blood, hemoperfusion, and the other one would be the plasma perfusion. In both scenarios, we have an extracorporeal circuit, and we have either standalone hemoperfusion device or in series with a hemofilter. And molecules bind to a particular surface due to chemical and physical properties of a target substance. It's a straightforward approach, and there are many, many different examples. We've heard about this, even up to Seraph that can bind living microorganisms. That's a rather simple approach, actually. The plasma perfusion is much more complicated. And Thomas has also alluded to this, the CPFA technology. Here we have one pump as well, but we have now a plasma filter that has to separate the plasma from the cellular components. And then in a second circuit, We have the cartridge that now binds whatever toxin want to be removed. And we have a hemofilter later on that mimics the hemodialysis approach, and then it goes back into the patient. So the advantage for this is the biocompatibility. There is no contact of cellular structures with the cartridge. It's only the plasma that goes over the cartridge. The disadvantage is the complexity, the price. It's really complex to handle. This is how the machine looks like. It's really common in Italy, not so much in many other countries where we're working on. And now I will list a couple of arguments that I think are worthwhile considering when we are performing blood purification. And the first thing is, and that's a conceptual question, is that the inflammation, this is an essential host response factor to fight any infection. Whenever I have an infection, let's say here in the example, my right upper lobe, severe pneumonia, I really want my system to perform an inflammatory response, to open up junctions, to let cells transmigrate, to fight the infections there. So the local production of cytokines, the activation of the complement, all these processes, they are evolutionary preserved mechanisms that helped us to survive. So inflammation as a target is probably not really the most clever thing to aim for. Just one thought. It's not a trial, it's a thought. Think about inflammation as a necessary response to an infection. Second argument, along the very same line. What did Mervyn actually mean when he was saying this is a life-threatening organ dysfunction due to a pathological host or dysfunctional host response? What does pathological or dysfunctional mean? We understand organ dysfunction. I get this clear. I understand infection. But when does a host response really become dysfunctional? Is cytokine storm necessarily something dysfunctional? I'm not so sure about this. So I think there are many scenarios in which a cytokine storm is absolutely required to get rid of my problem. So maybe even on a local milieu, that's something I really don't want to interfere with. When does it become to get pathological? Is the immune suppression the key component here? So we all don't know these rather simple questions. Imagine a young guy with a toxic shock scenario and an old woman with a bladder infection. They're both considered to have a sepsis or even a septic shock. They come from a totally different point with a totally different immune response. So I really struggle a little bit to define what's the dysfunctional host response here. So if we target this, it's really complicated because we do not really know what it actually is. And then the third argument, the compensation. So Thomas has shown this very nicely. There is always this sort of an hyperinflammation at the beginning, and then there's immunosuppression afterwards. I'm not sure if it's afterwards or if it's simultaneously. We really have problems with understanding these processes in terms of their dynamics and their time constant. So I'm not sure if the compensation is a good thing to tackle here, because if we are absorbing everything that we can, we are also absorbing compensatory mechanisms, kind of anti-inflammatory cytokines. So think of IL-10 or stuff like this. So any absorption might also immediately interfere with the compensatory process. Fourth argument, the lack of selectivity. That can be an advantage also. Remember all the targeted treatments, TLR4 blockers, TNF blockers, APC, they were negative and they were only following just one simple route. Maybe it's an advantage that blood purification is less selectively because we tackle more problems at the same time. And you've seen these pictures before, just the variety, the spectrum of potentially injurious stuff that can be removed. But at the same time, we remove other stuff that might be good, the compensation, the antibiotics. Thomas has mentioned this point himself. And you've seen the figure here as well. Sorry, this is half in German, I just realized. But there are things that are considered to be bad, like PAMs or DAMs or some cytokines. We want to remove them potentially, but we really don't want to remove stuff that we consider good things. And antibiotics is one example. I picked this because there's data for this. If you look at absorptive strategies, here are 3 antibiotics, vancomycin as a bolus or continuous, teicoplanin as a bolus injection. And you can simply see how the trough levels behave during kind of an absorptive therapy. Maybe here is best depicted with vancomycin continuously. We would like to have a level of more than at least 15, and this is the case without absorption. If we absorb, it goes down to 10. So we completely lose within 15 minutes the effectiveness of this drug You can see that this effect is lost after a couple of hours, but in the early phase, a lot of vancomycin binds to these devices, and this can be complicated. Next argument. The problem with monitoring this. So we are intensivists. So we love to monitor. We monitor hemodynamics. We monitor respiratory mechanics. We monitor urine output. But we have no clue about the immune system. So we really don't know where a patient is on these super simplified graphs that show hyperinflammation and immunosuppression. So it could be that it's here, there, some systems are here, some others are there. So HLRDR, that's a nice starting point, but it's really not dynamic, and that's really just the tip of the iceberg. So if we want to interfere here, we really need to understand where our patient is, and if an anti-inflammatory strategy like a blood purification makes sense, or if it could be harmful for a patient. That's really, I think that's of key importance. And next is the limited accessibility. So, and this is really something important if you think about this. And I heard this in a talk from Manu Shankahari like a couple of weeks ago about the compartmentalization. So if we look at the immune system, we look at the blood compartment. This is truly the tip of the iceberg, but it's accessible to us for diagnostics and for purification. But the infection usually is not the bloodstream infection per se. It comes from tissue, so from a different compartment. And we have problems to kind of tackle these. And look at the thought experiment here from Manu and his co-workers in this paper. If the immune status in the blood is concordant with the one in the tissue, inflammation or immunosuppression, then it's rather simple what strategy could help. But if the blood compartment is discordant with the tissue, let's say there's hyperinflammation in the blood, but in the tissue there's already a state of immunosuppression, and this is really theoretical experiment. It's discordant, and you really have no clue what you could do. So I find this really interesting by talking about purifying the blood if you have maybe a central nervous system infection. So then one point that Thomas has briefly touched, that's the lack of knowledge about what's really happening in the devices on these surfaces. So remember the boy that I showed at the beginning, I didn't show it for no reason. This is because we don't know what happened with all the chocolate in this phase. And I do love this paper because it brings a novel aspect to us as researchers, and it gives us new inspiration what we should look at. And look at this thought experiment here. We have a toxic substance, they call it enzyme A, but it doesn't really matter, that has an epitope that binds to a substrate that triggers the downstream cascade. If we bind this to our matrix, our blood purification device, in a way that the epitope is hidden to the bloodstream, that's clearly inactivated in this simplified experiment. But it could be that another toxin just binds differently to the surface so that the epitope is still available to the substrate, and then it would still be active, and it could still trigger a pathway downstream of this. And that gets really interesting because now it's somehow immobilized on this matrix. That would mean that our endogenous elimination processes that we have, the liver, the kidney, mechanisms of endocytosis, they could all not apply anymore because we have sticked this cytokine on the surface of the matrix. It's still active. It could still be active, but we cannot eliminate it anymore. And then at one point, it could be that the cytokines are even deliberated from this membrane. And this is really interesting because we have even some data from Peter, actually. I love the data, but it also shows some really interesting finding in this regard. If you look at this experiment, and I'm sure everyone has seen this, healthy volunteers challenged with a tiny dose of LPS, but they get really sick for a few hours, and they tested different scenarios of cytosorb, so cytokine adsorption. And the good finding there was that the devices really bind the cytokines. We couldn't show this before with that clarity. So congratulations on this. I love the data. But the data hide some information that's really crucial here. And the blue lines here are clearance data. So from a, let's say, a nephrologist point of view, my former life, you need to have a clearance of at least 20 mL per minute of something. Otherwise, it's meaningless. And you can see here that at the very beginning, the first hours, all the substances that are shown in this graph have a nice clearance that's clearly above 20. But it goes down with the time. Also no surprise. But the surprise here is IL-8, because the 0 is not at the bottom, and I put it in here so that you can see this more clear. 0 is here. That means after 4 hours, the clearance becomes negative. Negative means that this scenario from the colleagues that speculated that cytokines that are bound to the matrix can get deliberated again, they kind of detected this signal in the healthy volunteers here. So after 6 hours, there's a significant amount of, there's more IL-10 at the end of the adsorber than at the beginning. So it's negative clearance. I find this really, really fascinating. We need to look into these. So now Thomas has said, I will show a lot of negative trials. I didn't want to show too much trials. I want to give you some thoughts. But of course, I also have to show some trials. So the clinical evidence really you all know this. So this is for cytokine absorption. There are prospective trials. There are also randomized trials. They always show similar findings, hemodynamic stabilization, lactate clearance. But there, for example, in this trial, there's really no control group. So we don't know what's really going on here. If you look at the randomized trial, multicentric even, we always have the problem that the design is complicated, 7 days of treatment, but just 6 hours of absorption. And in these trials, we did not even find that IL-6 was really changed a lot. Look at the control group here in red and the treatment group in black. There was no change in IL-10, although clearance suggests there was a clearance, but only for, let's say, a good hour or something. Then probably it was already all saturated. There are also positive trials. I didn't want to show only the negative stuff. That's a propensity score matched analysis. And this is a SOFA comparison where the cytokine absorption was better than SOFA. But SOFA is from the year when we used this telephone here. So it's probably not the fair comparator. But they did the propensity score match. Although it's simple, you see that there was a 20% survival. So I agree with Thomas. There are positive data. But if we look at the meta-analysis, this is from early this year, overall, the data are more or less, there's really no signal for a positive effect here. At least if we look at this technology of adsorption in over 1,000 patients. And these are my last couple of slides on the trials. What really struggles me a little bit is that there are a few papers out that show sort of a signal for harm, which could be explained by all the theoretical ideas I've introduced before, but I don't know. It could also be that the trials are not well designed. But you can see here a cohort of 40 patients, protocol-based treatment without control group, and they have very strong inclusion criteria, refractory shock, high IL-6, so there's a stratification here, and a vasopressor dependency index that was high. And they matched similar patients. They very complexly matched these patients and found 48 matches, very sick patients, so for 14 in average high doses of norepinephrine. And they looked at cytokine levels. You can see that IL-6 goes down in both groups. Vasopressor also goes down in both groups. But the problem here was this graph. So where you can see that the cytokine absorption group has a worse and significantly worse survival than the control group. And this is something that kind of worries me a little bit, because the investigators didn't want to show this. They were believing the technologies. They wanted to show the opposite, yet that is their finding. And there's a second trial that shows a similar situation, and this is a different technology. This is now the plasma perfusion. I've shown before the complex circuit, CPFA, but this trial was a randomized control trial in 12 Italian ICUs, and it was stopped in the interim analysis after 115 patients because of the very same signal. And if you look closely at the Kaplan-Meiers here, you can see that there's an over-mortality in the first 2 days when this device was used. I don't know why. I've never used this device before, but it's another device of pure adsorption that shows a negative trial and even a signal for harm. So I think we really should be careful in considering this as relevant. And the third trial, the most problematic ones, but the third that showed a negative signal, was this ECMO COVID sepsis trial from Freiburg. Very tiny group, 16 versus 16. They wanted to show that they can improve cytokine levels. That's the primary endpoint. And they looked at mortality in the secondary. Primary endpoint was not different. You can see cytokine absorption brings it down, but the natural course of the disease also brings it down. I think IL-6 is way much too dynamic to use this here as the endpoint. But the concern is, again, the secondary endpoint, mortality, showed like a huge difference in terms of mortality. There was 18% survival if cytokines were absorbed. I really struggle here to explain this finding. I just want to say it absolutely without any emotion. This is the data, and we have to carefully look at them. Particularly as all the three researchers had the good wish to do something good for the patient. So it's the opposite accord. So let me summarize this talk by summarizing ideas or areas in which we need more knowledge. I think ideas for future research. And this is the pathophysiological understanding of the host response. That's the first step. So, and there are a lot of people working on this, but if we don't understand better the host response or what's really dysfunctional, we have a problem interfering with the system. You've seen that I tried to highlight a little bit that monitoring tools are missing. Monitoring the immune system is surely super complex, but we need to get better in doing this. And then the structure of the device. So we should also study what's happening inside the different devices that we're using. Remember the example of the molecules that stick to the membrane, but that might still be active. And then you've seen that we have lack of evidence on global RCT level. No doubt about this. And my suggestions for future clinical trials would to try to better stratify patients. Thomas has made this point as well. We have to make clever trials. We all know it, but we still don't do it. I don't know. I consider myself as part of the people who don't do the clever trials, but always say we need them. And then the dosing and the timing. These are super critical issues that we don't get right now from my point of view. And with this, I come to the last slide before the discussion. Two quick last things. If you're interested in this topic, we have a few days more running on the survey on ESICM. Please scan the code and answer the question. It's a 5-minute survey on your clinical daily practice. We will use this for a small paper in the collection that Nicole has mentioned at the beginning. Has just opened in ESICM Experimental. So send us your good stuff on this topic so that we improve our knowledge there. And with this, I'm at the end. I'm really looking forward to the discussion. Thank you very much.
Thank you very much, David. An equally excellent presentation. And you showed indeed that there's many gaps and many different parts of the whole process that we lack detailed information. This is true, of course. Now, the first question that came in is a good one because the people that are watching, they are going back to their ICU tomorrow morning and they have a septic shock patient and they want to know, should I do this or not? So this is the clinical decision, of course, every day. And so my question to both of you is that I think everybody agrees that there is no consistent clinical benefit in high quality randomized controlled trials so far, right? And so this leaves room for how people believe in it or not. And so I would say, as in the guidelines is mentioned, that at this moment in time, without a clear clinical benefit for a patient, this is so apart from the proof of principle that it does what it's claiming to do, but there should be a patient-centered clinical benefit. We cannot use this in every patient as a standard of care. So what would be your proposal to say, well, this is the ideal patient that I would actually consider using some sort of blood purification technique? Can I ask you first, Thomas?
Thank you, Peter. That's a very good question. I think, first of all these people, all these physicians in the ICU, our colleagues, they should participate to all the different trials, different studies, because as you understood very well, we need additional evidence. We need, and I think one point that Sasha, we agreed together is that further research is needed. Everybody's saying it, but we still need, so we need help from all these clinicians to enroll patients in the registries, in the randomized controlled trials, in the experimental trials, in order
I understand, yeah. Thomas, this is true, but I want to push you a little bit because the research needs to be done. But tomorrow, this intensivist goes back to his ICU. He has a septic shock patient, and he has to make the decision now. Do you think there's place to use it now as like a last resort treatment, or what would be the clinical picture that you would say I would use it?
I think it's fair to use in a refractory septic shock when, the situation did not get very well with the standard treatment, when there is there is no improvement within the last 24, 48 hours. I think it's fair to start blood purification device, because in some patients you will see an improvement. Although some people, they cannot explain why, they cannot explain what has been removed, there will be an improvement. And I think on a refractory septic shock, I think we have no problem to use it.
Yeah, thank you, Thomas. Any comments from your side, Sasha?
I mean, it's really hard. Before I've seen the negative trials from the last 12 months, I would totally agree with Thomas' answer. And now I'm on the con part, so I have to say, don't do it in routine clinical, because we have seen negative data. So it could be that Thomas did say totally right that there are some patients who benefit, but if the trials are neutral, it means that there are patients who might suffer harm. So it's really complicated. I try to individualize this, but I don't really know what are the means I should use for. Is it severity? Is it time point? Is it lactate? So usually if someone seems to be extremely hyper-inflamed, that could be a person I would consider a potential responder, but I really don't know. We're not using it as a routine strategy anymore.
All right. Thank you very much. I have one other question so far, or a couple actually. One question is that the blood purification, could this be used as the only indication for a central line, or must there always be AKI that in case there is a renal replacement therapy need, that you can use it in addition to that? This is something we can definitely answer. Thomas, maybe.
Yeah, I think it's easier to use when there is already AKI, because you can propose like a filter with renal replacement therapy for kidney support, and then you have these new filters with these enhanced adsorptive properties. So that's the easiest way to do it. But if you want to propose hemoperfusion, hemoadsorption, and these technologies can be used without any acute kidney injury. That will be very specific on the sepsis and not on sepsis-induced acute kidney injury.
Yeah, I think it's very good to emphasize indeed that the polymyxin B filter is just clearing endotoxin. It's not a renal replacement therapy. Cytosorb is not a renal replacement therapy. It's just clearing cytokines. That the Oxiris filter is actually different from that, because it's both. It is a renal replacement therapy, but it's also clearing endotoxin as well as cytokines. And so it's a decision to make. If you think that a patient might benefit from blood purification, I think then you should be able to put in a catheter or a central line to use it, even if there's no AKI there. But the problem is in this moment, as was alluded to by Sasha, it's really difficult to select the right patients and to know if you're actually benefiting this patient or not. Very true. Then the second thing is what is also interesting that we found in the endotoxemia study, and was found also in other sepsis trials, that for Cytosorb, for example, the saturation of the adsorber seems to be pretty quickly, within hours. So if we do this treatment now, we do it like one adsorber or filter per 24 hours, and then maybe 2 days, and that's it. This is not based on the data that we have. So it would be, in my view, make more sense if you do it, it needs to be more intense. Otherwise, you're not clearing anything. What would be your comment on that, Sasha?
So I totally agree. I was even surprised that the numbers that you measured, the IL-6, was not that dramatically high, as far as I remember, in the lower thousands, right? So if I consider a patient in septic shock, let's say abdominal sepsis, and in Zurich we measure a lot of IL-6 in routine, I sometimes see levels of 30, 40, 50,000. And even with your few thousands, after 3 hours or 4 hours, the adsorbers seem to be saturated. So this would mean if I have a patient with levels of 50,000 and I put him on this machine, I have to change after 2 hours. Otherwise, I can just not do it, to be honest. Mm-hmm. And it's something that I've learned, and we use it sometimes in very individualized scenarios. And I think based on the data you've shown, if we use it, we have to take it away after a few hours.
Yeah, thanks so much. All right, I have a couple of questions, and maybe one I want to highlight, and then we have to stop because the time's up. And this is the very specific indication of infectious endocarditis. Maybe Thomas, can you say something about this specific indication and if there might be a place for blood purification for these patients?
Yeah, actually, this is our next project with this Seraph technology, the device that can remove the bacteria from the blood, circulating the blood. And this is a technology we use for intraoperatively because the bacteria are released in the blood. And so for the endocarditis, we are going to launch in the same situation. We're going to try to do it perioperatively when the patients are getting operated for endocarditis. We're going to try this Seraph technology. I don't know the data yet, of course. We haven't not done any patient so far, but I think there's a good rationale to do it because it can remove this bacteria from the blood. So that's the next project.
All right. Thank you very much. I think it would be fair to say that there are many things we're not sure about for this treatment. We are still confused, but following your presentation, we are confused on a higher level. So thank you both very much. And with this, we have to end this webinar. Thank you for watching and listening, and hopefully we'll see you next time. And thank you very much again. Bye-bye.
Bye-bye.